welcome to the Intensive Outpatient Care Program, Care Coordinator Academy Panelist. I have special guests here today from our Wave 1 group, from Rees, Stealy, and from Sharp Community Medical Group. I'm going to have them introduce themselves. They're going to tell you their role and what facility they're from. They're also going to be sharing if they're from an IPA or a foundation model, if they're either embedded in the primary care physician's office, or perhaps they're doing virtual case management where they're making appointments for the super visits and going to the primary care's office, or perhaps maybe even a home visit to do their super visit. So they're here to really tell their story, to answer your questions. So really take a deep dive into these questions and ask them about their day in the life as a care coordinator for the Intensive Outpatient Care Program. So we thank them. Let's give them a welcome.
Thank you. My name is Wiara Jackson, and I'm with Rees Stealy Medical Group, and I'm a social worker care coordinator. And in my role, I do the home visits, and I also engage patients while they're hospitalized during their admission.
And my name is Kelsey Stinson. I'm the lead triage and also lead for the section of IOCP that we have now. We actually branded it Senior Enhanced at Rees Stealy, and we do have the model where we are embedded in the clinics as well. We're a large medical group.
I'm Scott Heimer. I'm the project coordinator from Rees Stealy, working with all these lovely ladies.
Thank you. My name's Kelly Roberts, and I'm a lead at Rees Stealy as well in our population health department, and I manage the group of our chronic care nurses that are embedded within the clinics.
Hi, I'm Suzanne Warren. I'm with Sharp Community Medical Group. We're an IPA, so I am not embedded in the physician's office. But I am a case manager, usually doing home visits, occasionally going to the PCP office.
So maybe while people are getting ready to come up here, Scott, I'd like to have you start with talking a little bit about your project management. It's a pivotal role in the IOCP program. We have found groups that have strong project management are very successful with the operational aspects, allowing the nurses to do what they do best. So can you describe the project management interactions across your organization, the leadership, the clinical team, just kind of the day-to-day operations that have really assisted the nurses and the health coaches and the social workers to do their job on a daily basis, Scott?
Sure. Really, I meet with both Kelsey and Kelly on a regular basis as issues come up. We discuss what the best way to do thing is, you know, how we want to proceed to meet the guardrails for the program, you know, how best to get the consents, track them in our documentation system, keep track of assessments that are due, missing, overdue. Really, the whole program, we meet pretty much daily, discuss what's going on. It's really been a collaborative group, get their input on what we need to do to get everything done in a timely fashion and keep track of it so we can do our weekly and monthly reports accurately and keep track of the patients as we enroll them.
And just to add to that too, Scott is extremely pivotal in what we do at Rees Stealy. And as he said, to make sure that we get in the data accurately. Everyone makes mistakes on a regular basis, which we could catch so easily when we had 100, 200 patients. Mm-hmm. Now that we're over 2,000 patients, a few errors here and there add up very, very quickly. So he's been able to pull data reports and find those errors so we can go through and fix them as we're going along. So we're not going to have to fix 500 at one time. So.
And catching your mistakes earlier is generally better, especially we have about 30 nurses and care coordinators enrolling patients. So I think our best week ever was we got 81 patients in 1 week. So just, you know, making sure all those assessments are in the EA tool so they can be scored, attached to the documentation system. It's a lot. So if you do get behind, it's hard to play catch up. So, and then I'd also encourage people to start thinking ahead when it's time to do the repeat assessments, have some sort of process in place, you know, depending on what your system has, you know, if you have to task yourself in your documentation system, or you can use the EA tool to run reports to see the assessment due dates, and we use the EA tool for that a lot. just send out reminders, hey, these assessments are coming up due this month. Depending on your system, that can be really helpful, and a lot of people really appreciate it.
Thank you. Can you talk a little bit about your team huddle that you have on a weekly basis, and how you as a project manager then have helped facilitate getting information to the care coordinators?
Well, we have a monthly meeting with just the IOCP group that works, and then, like I say, since a lot of the key leaders are in the same office downtown, we collaborate amongst ourselves along with Chris, the manager, and then really the leads take the information back to their teams to disseminate it. That way, they're involved in the communication back and forth with their team, and that seems to work out pretty well, I would say.
Yeah, I think so. We seem to problem solve together as things arise, figure out a solution, and then Kelsey and I distribute the information to our team of the care coordinators.
Good morning. Thank you for you guys for being here too. I wanted to ask a couple questions about community resources. I'm a social worker, and if you can, it's actually going to be, I'm going to ask you two questions. One is, describe how you established your community resource network first, and then also, how did you develop the relationships with those community resources?
When I first got to Sharp Rees Stealy, there weren't a whole lot of resources in place because I was the first social worker to ever be employed within the medical group. But to my advantage, I have worked in medical social work for the past 10 years, and so I was able to kind of accumulate the different community resources that I utilize now and share with the entire team. We do keep that on a shared drive so that everybody has access to it when they need any type of community resource for their patients. But I am also available on a consultation basis to help consult on different cases that are very psychosocial heavy, but I'm not the case owner for that particular patient. So I'm utilized in that way, in addition to the shared drive that has all of our community resources on that.
Is that shared drive just for your folks? Does that ever, can it be utilized with the doctors that you work with, like, you know, the embedded clinics that you're in? Can they access it, the MAs or the other staff members, or how does that work?
Our population health department has access to it. I'm not sure if the physicians' offices have access to that. So at that point, they'll refer to our department, and then they're funneled to us that way, and that way we can assist the patient with whatever their needs are.
Just at Sharp Community Medical Group, we do have a really good database that's called the CARE program that someone manages. And it is organized to like transportation, caregiving services, and so someone is responsible for updating that. And it is actually what comes along with that is a printout that you can send to the patient, so it can be documented also that you provided that research. But actually, resource. But it's very helpful because we do not have a social worker. So in terms of our role, it really is kind of one-stop shopping. And so it's been a very, and in terms of establishing relationships in the community, we really have encouraged in-services in terms of people from the county, because the county does have case managers, especially for behavioral health, issues. And so then just over time, developing personal relationships with those people too has been very helpful.
Oh, hi. Thank you for joining us. Particularly this is for Sharp Rees Stealy. It's kind of a two-part. So you have this really large volume. I was wondering what your caseload was for your case managers, how doable it is given, trying to weave. And I know you capture a lot from the medical groups at the facilities, at the buildings, the medical buildings. So that's kind of like your first visit. Some require follow-up visits, I'm sure. So what's the caseload number? How doable is that, number one? And number two, you still have the 30-day call, I'm assuming that everybody has to do. And are you able to, have you figured out maybe tasking the CCs to take on the lower acuity calls? And if you've had any success with that?
Yeah, actually, when we first started this, Wiara was our first person going out and getting patients, and we didn't know what the ideal caseload would be. We didn't know how intensive it would be. So she went out, I think, engaging over 160 patients, and we said, whoa, this is too much. So we did back down a little bit. We do have this standard of 130 for each of our case managers, and we expect them to keep up that caseload. Kelly can speak to maybe a little bit more of what they're seeing in the clinics and getting those patients in the clinics. But for our teams, we've been able to identify the lower acuity patients, and we actually hired 2 brilliant MAs who are here, who are following up with those patients every 30 days, working with lifestyle changes, helping them out, and then having that resource of the social worker or the RN if questions come up on medications or on certain clinical questions. So.
Yeah, and our nurses that are embedded in with the clinics initially had around 40 to 60 patients, and they were providing very intensive follow-up for their patients. And as our caseloads grew and we reached out to more and more patients, we determined that we did need someone else to help with the follow-up. And that probably happened around 80 to 100 patients. I think the nurses started feeling the caseload, and they were having difficulty keeping up with those 30-day outreaches. So we now have an MA that works with our nurses that are embedded in the clinics, and initially when the patient has more acute needs, they're working with the RN, and then as they become lower acuity, they're working with our MA on lifestyle changes, working on goal setting and things like that. So that's how we've managed a caseload of around 125 to 130.
Hi, thank you for being here. I just want to expand a little bit more on understanding the non-licensed role that you were talking about with the MA and how that looks as far as you have an acuity rating. So there must be a level at which it gets to a point where you can say that can be passed off to the MA. And then how does that look like as far as it appears that what you're saying is the MA is calling them and following up on a monthly basis. And what is the RN, although they're a consultation role, what is their role in as far as connecting with the patient if the MA is doing that? If you could describe that whole process of that handoff or what they're doing.
Yeah, and I think maybe Wiara can speak to a little bit of how you're able to identify the acuity. But when we do have the MAs following those patients, it usually is that we've called them a few times and they want to work on exercise, get walking, they want to find a gym, they want to, because there are so many different areas that people want to goal set, and we want to motivate them to do whatever small steps they want to do. Over the process of a year, it changes a little, it does change, but usually they're focused on either more lifestyle changes or to get into a psychiatrist, to get into different resources that are going to take a social worker. But the lifestyle changes are more, fitted for an MA or non-licensed clinical person. So.
And when those patients are very psychosocial heavy, which for me is they're positive on their PHQ for their depression, and they're wanting to receive treatment, they're wanting to be engaged with a psychiatrist or a psychologist, then I continue to work with them on those things until they are more stable and feel more comfortable in being engaged with mental health services. And even if they are involved in some very clinical, active, chronic treatment, such as treatment for cancer or anything of that nature, I make a point to remain engaged with them to make sure that along the way that they're receiving the resources that they need and the support that they need throughout those types of experiences.
And I think if at any point the patient expresses more clinical needs, they have more issues going on with their medical condition, then there's collaboration between the MA and the nurse. Or if it was a social worker, then she would connect with a nurse and we determine the next course of action. So once the patient has transitioned to have an MA do the follow-up, it's not an MA from there forward. It can go back and forth between the MA or the RN depending on the patient's needs.
And one thing I'd add too is we kind of envision it as a care team. So even other nurses with other specialties, we've developed a lot over the last year. We have heart failure nurses. So sometimes perhaps Wiara can carry the patient on her caseload, but still consult with the heart failure nurse or the diabetes nurse. So really, even when I'm doing some of the reports to see what's going on with the patient, sometimes I'll see a variety of contacts from really a number of different people. So we seem to have done a pretty good job of creating the care team, handoffs back and forth with yet one, care coordinator managing the patient, ultimately responsible for the assessments and so on.
I agree, and I think that we've had the philosophy of IOCP in all of our programs. So we have multiple nurses and social workers that it may be a chronic care nurse that's embedded within the clinic that's engaging patients. It may be a heart failure nurse working from home, and then that nurse would connect with another nurse. Let's get that face-to-face interaction. So I think that's been key, is that we have all the different disciplines working on this project and all of us as a team together.
And that's a good point too, Kelly, because we kind of integrated the IOCP model in most all of our programs. Rather than having a lot of different programs with a lot of different criteria, a lot of it we took the IOCP care model and integrated it into all our programs, just so it was easier than trying to keep track of too many numerous different programs.
And just to add from SCMG, our IOCP program is somewhat smaller than theirs, so that we still do have existing different programs like the disease management and post-discharge call. So we have 3 full-time case managers and 1 part-time, and we are able to change the acuity level and pull a bi-weekly report. And so sometimes we can just, not in a maybe as formal a way as they do, but where we can get either a unlicensed person to make telephone calls if the acuity is very low, and then a nurse to do higher acuity if our caseloads start getting high and difficult to do that monthly follow-up. So,
can the panel address how you set weekly or monthly enrollment goals?
Really, when we signed the contract to join in, our goal was 2,000 patients, and I'm sure, like everyone, you have no idea, excuse me, how you're going to get there. So we just started, and really, once we kind of hit our flow after a couple of months, we set our target because we wanted to hit our 2,000 patients by the end of the first year, for a number of reasons, but partly to capture the maximum PM reimbursement. Since the grant period goes through the end of June next year, we wanted to get our 2,000 by June of this year. So really, once we found out kind of how many we could get, we had a goal of 200 per month. So, and I would say our caseloads are transparent. So we do monthly reports of all our care coordinators and their caseloads for all our programs. So everyone can see how many engagements other people are getting. If they have PHN visits for the chronic care nurses in the clinic, everyone knows what everyone else is doing. So there really isn't a whole lot. We know our team goal, and really, I was surprised how often I'd get emails from people just asking, hey, how are we doing this week? Are we going to make it?
Definitely. I think that transparent productivity has been very driving for the team. Prior to being in this leadership role, I was a care manager, and working in that setting and knowing that, okay, you don't want to be falling behind. You want to work to your fullest potential, and then the nurses motivate each other as to, oh yeah, my caseload's getting higher, how's yours doing? And I think it was a good thing for our team to be transparent, and it was motivating for them.
And as far as our group, we already said that we're an IPA, so our challenges are a little bit different in as much as we're not embedded in a clinic or the physician's office. So we do have someone who's here, Beth Nelson, who does go into the hospital and recruits or identifies patients for our program. And I think, did you mention you have 10 case managers?
That are embedded. Oh,
or that are embedded. But in any event, I mentioned that ours is a smaller group, about 3 case managers. Our goals are somewhat smaller, about 10 to 20 per week.
Hi, I wanted to know if you have a process in place for educating and engaging the physicians who don't really buy into the program yet.
We actually have a wonderful medical director, Dr. Agnihotri, who's been pivotal as well in getting everything set up with our IOCP program. And he really works with those physicians to let them know what's available to them. Fortunately, with the SRS model, our physicians are employed, so it's not the IPA model, and they love the help. They love that we're there in the clinics working with those patients because they're getting less calls, and they have that feeling that the patient's covered. They don't need to worry about it because somebody's managing that patient, getting them the resources, and working with that patient. So there are certain physicians I know that have been slower to come around than others, but I would say the early adopters and the middle group have come on board a while ago, and those late ones are already coming around.
Yeah, I agree. And it was a slow process. It wasn't right out the doors for those of you that are just getting up and running or working with having nurses embedded. Or, you know, a lot of physicians aren't used to that. They're used to managing their patients on their own between them and their nurse or MA, and that's it. But over time, I would say over probably a 2-year process, the physicians have really, like Kelsey said, grown to love having someone to rely on for those issues that they're just not sure what to do. They'll grab one of our nurses or we have a triage nurse that's centralized processing all of our referrals, and the physicians have grown to love it. But part of what's helped with their buy-in is those small wins with the physician. I'm here to reinforce your plan of care, to reinforce to the physician that after they leave the room with the patient or after that appointment, that the care coordinator is there to help answer those questions, and the patient or caregiver can call the care coordinator, and the physicians realize, oh, this could be a good thing for me, freeing up a little bit of my time.
Well, we do get a lot of referrals through the triage nurse. So Janet and Chris and sometimes Kelsey and Kelly will round to the physician's office, just tell them some of the things we have going on. So our message generally is if you have a patient that needs something, just call the triage nurse, send them an email, we'll see what we can do for them. And I remember from January of this year, 41% of our IOCP patients came via physician referral that way. So a lot of times they don't even necessarily know what they're referring to. They just know they have a patient who needs more help. So that's where the triage nurse comes in. They find something, and a lot of those people are eligible for IOCP and great candidates.
And we tried to really make it as easy as possible for them. When we round, we let them know the programs that we have, but we say just send it over and we'll take care of it. We're also putting a referral and e-referral in the EMR, so they can just easily refer to us, and we can do that assessment and figure out where they're most appropriate. They just give us a little snippet of what's going on with the patient, and we'll figure it out.
And some of those late adopters come around as soon as you have success with one of those patients.
Yeah.
And I would just say that we have a similar model, but a lot of education from our leadership going to the physician quarterly meetings, and also they have different group sessions, and then also trying to work on the EHR so that the referrals can be made very simply.
I'm a new hire social worker onto an existing care management team, and I'm just curious from the social worker, how do you get your referrals? Do you get them directly from the care managers, from the physicians, from clinic staff? And then my other question is, are you actively enrolling patients into the IOCP program?
Sure. To answer your first question, all of my referrals also go through the triage nurse, so that everything is just very centralized. That way, I'm not inundated with 100 referrals for some sort of psychosocial need, while also trying to manage my caseload and engage patients. So to answer your second question, I do engage patients as well by doing the home visits. I also engage them while they're admitted in the hospital. I collaborate with the inpatient case managers who provide me with a list of our patients, and we identify the possible candidates for the IOCP program, and then I go and visit them. And I've pretty much had a 100% success rate in the hospitals. And I've never had someone in the home turn me away. It's a big deal that they let you into their home to interview them and see what things are going on with them so that you can kind of fill in the gaps in their care and help them out. So everything goes through triage, which has been very, very essential to how I operate.
And to just kind of add to that as well, like she said, when we first found out, when the physicians first found out that we had a social worker, everyone was sending over referrals for the social worker. It could be anything with a patient, and a lot of those can be managed by an RN case manager, especially since we do have all the resources, the community resources. So to go through triage and give the social worker the appropriate social worker consults and give the RN case manager the social work consults that, or referrals that were appropriate for them, it just speeds up the process as well. So she's not going to have to be inundated with all of those referrals when they first found out.
For those of you who don't have a social worker, don't panic, because I would say that probably that's one of the most enriching experiences that I've had as a nurse in this position, to really become familiar with a population and their needs and how to interact with them and the community resources. So in any event.
I have two questions for you guys. Number one, how do you manage your time when you do your home visits and you come back to the office and you need to enter all the information to the A tool? That's question number one. Question number two, what is your turnaround time to return patients' phone calls?
As far as how I balance my day, I usually try to do all of my data entry and documentation when I'm not calling or going out on home visits. So I kind of split up my days, which kind of, it works out a little bit better for me, except for when you're engaging in building your caseload. I was out 5 days a week doing home visits. So in between each visit, I was in my car with the laptop. So it was a little less, it was kind of challenging to get all of the documentation done and everything entered into the EA tool, but it kind of happened in bits and pieces. And so once you have a larger caseload, you're able to kind of divide up your week or portions of your day to dedicate one section of the day to documentation, one part of the day to home visits, and then perhaps the next day is fully dedicated to follow-up calls. So it kind of evolved over time depending on how many people were on your caseload, because you do have to continue to keep up with the follow-up calls, and that's where we were running into challenges. When I was up to 160, it was very challenging to be able to keep up with that, and it wasn't happening, actually. So we just kind of changed our approach and adjusted it to be able to meet our goals and meet the criteria for the program.
If I could add to that in regards to the documentation, what we found with our care managers that are in the clinics, they were not directly, we decided to not have them directly enter the information into the EA tool. We have a care management documentation system that has already been in use, pre-existing. So that group of nurses does their documentation in that system, and then there's a way that they can notify our MA, like a task to transcribe their assessments. So our MA then goes into the EA tool and does all the work in there. So for that group of our nurses, we removed the direct care providers from that piece of using the database and the EA tool.
Specifically for Suzanne, since you are more in the home than embedded in the offices, I'm curious about your physician engagement strategy, not so much in getting them engaged in the program, but engaged in the care planning and in the whole process of, now this is what I'm doing with the patient and I need your buy-in as well.
I think that it really does vary because you know, it's not 100% in terms of really having close collaboration with the PCP. We do have a shared EHR, so in terms of being able to let the patient know and several platforms to let the patient know that I'm, aware of different things that are going on and things that have been discussed by the physician. But between the physician and myself, a lot of times it is telephone, conversations. Also, depending on how complex it is, if the person really does have some challenges, then there's more collaboration, with the physician. And there has been an effort to put some of us directly collaborate with one physician office and to get more referrals through that way. But as their experience, most physicians welcome the help and the support. And basically how I handle that with the physician, I say, all you've got to do is mention my name. All you've got to do is say that I'm working with the person. And I think that in and of itself makes a difference. And also in IPAs, and I'm sure the same with their physicians. Physicians are busy, so that the times that I have met in the physician office, I haven't found that it's necessary to sit in on that appointment that they have with that person, but really to kind of model what the picture is, or that shows the nurse and the physician just having a face-to-face, if it's even 3 or 5 minutes. Again, I think it's just that impression and buy-in of collaboration. So, and I think that takes a load off what the physicians are concerned about, how much extra time. It's not going to cause them any extra time, it's going to save them time.
Hi, my question is, what is your actual criteria to participate in the program for your patients, and has that changed over time as you're getting such a large population in the program?
Well, typically, before we had IOCP, I was part of the triage as well, and we had the disease management, we had the chronic care in the clinic. So we were a little bit more of silo model at that time. And if I had a patient triaged over to me, referred over from inpatient case management or from a physician that maybe was elderly, they maybe had pneumonia and they were leaving the hospital, or a CVA, I didn't really have anywhere to put those patients. So with the IOCP model, we've been able to really take on those patients, and Kelly can kind of speak to, they're seeing all of those patients that are leaving the hospital. So those senior patients that are leaving the hospital, we're going to capture them. They were in some sort of acute crisis. So those are the ones we want to capture. We want the higher risk patients because we want to have an effect on them. If we get to the healthiest patients and we talk to them for a year, they're not going to need us as much. So it's typically the patients that have been in the hospital, the ER, that are coming over from the physician. The physician thinks that they need other help, and coming through our triage. And we have not had any shortage of patients either.
That's right. The nurses that are in the clinics scan the physician schedules every day, and then they have a few other reports and such that come to them with patients that have been recently discharged. So we're catching, right now we're at 90% of all the post-hospitalized seniors that we're able to engage at that post-hospital visit within ideally the first week after discharge. And during this time, we found that this is a great opportunity for patient engagement because they've just gone through something. During that transition of care, there's a lot of information that can be lost. The nurses do a very thorough visit in with the physician, ideally for the entirety of the visit, in order to capture everything from the start of all the things the patient is explaining along the way of what happened during the hospitalization, what's going on at home. We ask the patients to bring in their medication bottles, and that's a big thing at the visit and that face-to-face that's been so important is the medication reconciliation. Here's the list of what the hospital sent them home on, here's what we think they're on, and here's their pill bottles, hopefully, and let's talk about, tell me about all of these, and we go through them so that by the time they leave the office, we have a medication list that's up to date for the patient caregiver as well as the physician, and then we're all on the same page. So the post-hospital visit has been really a great opportunity for us to work with patients.
So can I ask another question in regards to that? So if it's an elderly patient, a Medicare patient age, one-time hospitalization for pneumonia, then see them once and then close that case? Or are you continuing to follow these people that might have had only one incident in the hospital and are now doing well? How long do you keep those kind of cases open?
And it really depends, because when they're seeing the patient, they're either going to deem that they do have more needs and need that follow-up for a year and open them as the senior enhanced, the IOCP, or they'll follow that case for 30, 60 days and they'll have everything met and they'll close them. But then we won't go through the consent and assessments for those patients. And then as long as, with the criteria, we do see any patient that has Medicare if it is referred over by the physician, but our model does typically have more managed care patients. I think it's about 70% of managed care and then 30% fee-for-service. So.
Another thing, piggybacking on what Kelly was saying about the post-hospital visits, the referrals come through the triage nurse, and we put them into our database, and then weekly we pull a list of upcoming appointments. So Sarah, the MA, looks at the schedules for the upcoming week and notifies the chronic care nurses that, hey, you have these patients coming in this week, try to get them if you can. So that's another way of patient identification. So they've been referred. This is just the physical process. We bump up the reports out of our database, so at any time they can look up, they'll have tasks to schedule patients, and she can look up the schedule to see who's coming in this week and to let the nurse know that they're coming in.
So in your health system, you're not asking the PCP, is this a patient appropriate for our program, or they do not have to give you permission? It's just carte blanche, you're picking your patients and telling the PCP, this is now my patient?
Yes.
Okay.
That's the benefit of not being an IPA.
We do have a large case management team. We have post-discharge calling. We have disease management, which is more telephonic health coaching and education. And then we have complex case management, which a lot of their referrals comes directly from the PCP office. So actually, the IOCP, we do get referrals from them because their program is more for post-discharge. Maybe they're open for a week or a month, but so there is a handoff that they'll come directly to us. And actually, we do share an EHR, which is helpful because sometimes people who are in IOCP, they actually do sort of float through other areas. So you do have an opportunity to have a little bit of a lightened caseload because they're interacting with those people. And then again, as long as the patient knows that you know that they did this, I think it gives the impression of, that it really is a collaborative thing, even though in our case, we still really do kind of work more in silos. But we do collaborate to try and put the person in the best place.
I have a question for you. How else are you identifying and recruiting patients into the program? I know you said you make, a list and of the discharge from hospital, but how else are you doing it? Do you have somebody on staff that is going through patient records and identifying them? Can you give us some more ideas on how to recruit?
When we first started, we did have the high-risk list that we were able to pull that had certain criteria, 5+ chronic conditions, the ER visits, recent hospitalizations, and we went through that high-risk list to be able to identify, and we cold called patients to try to do home visits with that. Ever since this really took off in October, we've not had to use any of the high-risk list just because inpatient case management and physicians are giving us so many referrals that we're just trying to keep up with what we're doing. So once we've really got that ball rolling, it's just keeps coming in.
I have a question a few questions that would fall under the umbrella of organization. I would like to hear, as you grew, it sounds like pretty quickly, if you could share best practices around how, not necessarily you organized your day, but more how you organized your who's due for a visit, did you have shadow charts, like how you did those kinds of nitty-gritty organizational pieces.
Well, in our documentation system, the nurses or any of the care coordinators have the ability to set up like reminders for themselves. So they do the initial assessment and then they're able to set when the next assessment is due. They're able to document their phone call and then set a date for them, in 30 days, this is when it's due. So then when they come into work every day, then they have a list of what's due and when it needs to be completed by. So that's helped keep track of all the documentation type things and phone calls and assessments.
And to be perfectly honest, when we first started rolling this out to our other groups, the CHF nurses, the diabetes case managers, we did not have our case management system, documentation system set up for it. So we were doing a lot of workarounds, and it wasn't, that's where a lot of the mistakes came up. We were having to do a shadow case, an empty case where we didn't want any documentation to help them identify that it was an IOCP case because we didn't have the capability to do a dual. Now we can do a dual, but when you roll it out so quickly and you do grow so quickly, you go with it a lot of times and then you realize, oh, this is not the best way to do it. So you have to find a workaround until you're able to kind of fix that problem. And we definitely did have some issues come up with that, but we have been able to navigate and brainstorm with each other, collaborate with other teams, and figure out a way to get it worked out.
And I think having a dynamic team that is open to change has been key. When we're hiring, we talk a lot about, how do you deal with change in your workflow, because it's all the time, because we're constantly identifying how can we do a better job for these patients, or it'll be because we realized we missed something, especially in this process. Like initially, we obviously weren't thinking about disenroll processes. So that was something that along the way we had to identify and get the message out to our teams, like, wait, like there's a process for these patients rather than just a patient that you would close the case and you're no longer working with them. For IOCP, obviously there's a lot of other things along the way that need to happen. So that was something we found.
Or even the graduation process. It seems so far away when we started, and all of a sudden we come up on a year and we've got to figure out how to graduate these patients because they've been with us a year. Or
to keep them. So we're keeping a database, tracking them, like who did we keep, who really is ready to be on their own and have improved their PAM score and feeling better about their way of life and everything. So a lot of this stuff, it does sneak up on you. Even the repeat assessments after 6 months, all of a sudden it's right on you, and you kind of figured, oh, we'll get to that when we need to, and then all of a sudden it's there, and you have 100 people that you hadn't really planned for that. So, and the other thing I might, if there are any project manager types in the room, is just like start looking for your mistakes early and often, because if you look for them, you'll find them, and it really is an opportunity to try to fix them before it gets too big of an issue.
And to add to that, what's been essential operationally is the addition of our MAs, helping with the follow-ups, the reassessments, and the graduation process. They've been integral to our entire process. So they pretty much saved me.
Just a quick question for SRS. How are you tracking hard savings now that you have the volume?
We haven't gotten a lot into that yet. Most of what we've tracked we did our own repeat PAM score analysis, and the statistics from the first 144 patients that had their repeat PAM score done, they had an increase in activation of 38.9%. And then we also looked at admissions and readmissions, and the patient population, the same as it was 187 patients, I think. Out of those 187, we compared people who'd been in some sort of case management before, and then the first 187 patients that participated in IOCP, and the third group was patients that were eligible that did not participate for one reason or another. And we found that the group that were participating in IOCP were 50% as likely to be admitted. So it's just a first run of 187 patients, but it looks good.
So as the project manager, do you have strategic planning processes in place to be looking at that 3-6 months, a year from now?
Well, yeah, we have a whole team of data analysts, and they do a lot of that. for us, and really we have a lot of reports that we do for other meetings with our medical director and finance. So there's talks about it. Nothing's planned yet, but it's in the works to do another analysis of the admissions and readmissions in the near future. And I've started doing the repeat PAM score analysis again. So now I think I have, oh gosh, probably 500 repeat PAM scores to look at. So
I have a question about patient identification through the transitions of care. So when the patient moves through those transitions, whether it's providers or different care settings like SNFs, how do you identify your patients, or how do they know that they're a part of your program?
We have a few different ways that we track those patients. We do get a list of hospital discharges. We also work with the skilled nursing facilities, and our nurses get a list of all those patients as well. And during that transition of care is another opportunity. We want the patients to come in and see their primary care physician. So if they don't have a scheduled post-SNF appointment, then the nurses are scheduling them for that. And we also have a list of patients that have canceled their post-hospital or post-skilled nursing facility appointments. So the nurses are reaching out, why did they cancel, and are we rescheduling?
Just to add to that, we also have, to let the physicians know that we're working with them, we have an alert in our EMR that actually comes up as a red continuum of care. They can go to the flow sheet, an area of that, see which program they're in. We have Senior Enhanced, which we call our IOCP, in there, and then we have the case manager's name and number, so they're able to contact them.
And our inpatient teams are on board as well, so when the patient is in the hospital, then we're getting notification to our triage nurse of that, and the triage nurse is monitoring during the hospitalization or skilled nursing facility stay. So then the nurse at the clinic or that's managing them telephonically can then prepare for the discharge.
So do all of those reports that you're talking about go to the triage nurse, and that nurse, or who's actually funneling through all of that information that's coming in?
The care coordinators, the nurses, are going through those. They find, okay, this is my physician, this is one of my patients, and a lot of times it's a patient they may already be working with, so it does save them time, because they're like, oh, yep, I already have that one on my schedule for next week, they're coming in, or, oh, I just talked to that patient's son today. So it's the direct care providers looking through it for those particular lists.
And those are for the nurses that are embedded in the clinics, and then any other lists or any other things would go through triage for disease management and the complex case management, and our specifically IOCP care coordinators.
I had a question about shared action plans. One is, when you initially do a shared action plan with a patient, do you dispense any kind of written material to them about this is your shared action plan, and then in a follow-up, when they do achieve that goal, how do you move forward? How do you track your shared action plans?
In our database that we do all of our documentation, we have that as part of our documentation, the shared action plan. And once that's completed, that gets mailed to the patient along with any resources that we discuss during the super visit, so that they're in line with us and know that we're rooting for them and here to support them in meeting their goals. So once they meet their goals, then we discuss about what else they want to work on. What else is in your life that you would like to improve upon? And sometimes it's just maintaining where they are and how far they've gotten, and sometimes they want to change it to something completely different. And when we update our shared action plan in the system, it keeps a carbon copy of the previous goal and action plan steps that they want to take. So you can see the progression and the history of any changes made, or if it has just remained the same for the entire year.
And then just one other question, because you mentioned something I'm not familiar with, the graduation process. Can one of you talk about what that involves?
Well, really, that's because the grant pays PMPM fee for people to be part of the program for 12 months. Really, part of it is getting those final assessments in so we can track the progress of the patient over time, and then it's a time to reevaluate whether the patient really needs to be followed or not. So if they don't need to be followed anymore, we call that graduation. And we're also tracking whether sometimes the nurse case manager keeps the patient. Specifically, some of the COPD and heart failure patients, they keep them on their caseloads. And maybe the frequency of the calls goes down to quarterly instead of monthly. So it really involves a number of different decisions, not just, it's not just are you going to follow them, or maybe somebody else is more appropriate to follow them at that point. So they could be graduated, they could be no longer in IOCP. Part of it's for the reporting too. We don't want to count contacts outside of the program. So we change their case status in our documentation system, and maybe they end up being referred to another care coordinator or diabetes education, or we have other health education programs they can go and be a part of too, whatever's most appropriate. Mm-hmm. So it's just an analysis of where the patient's at and where they need to go.
And I think that is a good time to evaluate, like Scott said, how the patient's doing, so that the nurses and the care coordinators, social workers are able to keep enrolling patients. That way they don't get maxed out and unable to take any new patients that may need them.
So you're looking at our entire care management program. We have a program manager, we have a medical director. This is my partner Katie, and she handles the transition from the hospital. I am everything else. I am the social worker, I am the case manager. I'm the one that is going to be embedded into the doctor's office. I'm the one that is hopefully going to be there for their post-hospital or post-SNF appointment. So we're looking to add a medical assistant because it's pretty obvious as one person, I can't do all that. We are, again, we're new, but we're growing exponentially by 8 or more patients a week. So we are looking to hire a medical assistant. And we're figuring out, what's legal, what's not legal, what can they do. We are going to send our medical assistant to our local junior college, and they're going to become health coaches. So they'll have some training. My question I'm finally getting to is, can these non-licensed health coaches, can they do the PAM and PHQ-9, and can they do these because they're assessments? So can a non-licensed person do these assessments with my being there for backup? Let's say the PHQ-9 was definitely a positive score. This person is very depressed, so they would, of course, come right to me. But I mean, can they do these assessments?
Yeah, so in our clinics, actually, with our physicians, we have MAs that work very closely with them and that are doing the PHQ-2s in the clinic. So we already knew that within Sharp Rees Stealy we had guidelines, we had certain things set up. But what we typically do is that the social worker or RN go to see those patients the first time, do that face-to-face, and do those initial assessments. Because then they can really assess what's going on with a patient, make sure they have all the resources right away, see what their acuity level is, and really be that face right away with that patient, because it's unknown. We don't know what's going on with that patient. And then once they deem that the acuity is a little bit lower, that they need a lot more lifestyle modifications and help, then our MAs are doing the 6-month follow-up for the PAM and all of the final assessments at the end. And of course, if they do come across a positive PHQ-2 score or maybe even a very low PAM, they would bring it back to the RN or social worker and not close out that case. We would find another place for that patient because they do have ongoing needs.
Thank you so much. A round of applause for all of you panelists.